Good morning, everybody. It's my pleasure today to introduce our speaker, Dr. Brian Skotko. Brian is one of the newest members of our genetics division who joined us this last July. Brian is a graduate of Duke University, went there for his undergraduate, then came to Harvard Medical School, went on to Harvard Kennedy School of Public Health and has a master's in public health, and then did his pediatric residency training at Children's Hospital, and then finished his medical genetics fellowship at the combined Harvard MGH Brigham and Children's Fellowship Program. And we were lucky enough to recruit him this last year in July, where he came on board with Dr. Ali Schwartz as one of the co-directors of our Down syndrome program. And he joined our program that was just sort of in its infancy in regards to the care of children with Down syndrome, was not as organized nearly as it could have been. We did have as the foundations a program that was started by Dr. Jose Flores, who started one of the premier adult Down syndrome programs in the country that was here at Mass General Hospital. And the charge that I gave Brian and Ali when they started this program was to really leverage the strengths that we have here at Mass General, where we see patients of all ages, and to develop really a world stellar program in Down syndrome. And the program was to care for patients both starting really from the prenatal period in terms of counseling and transitioning through the children, toddlers, infancies, and up through adults, and to develop a program that really would be world-class in the respect that it would be a multidisciplinary clinic and involve really the strengths that we have here at Mass General Hospital. And when I say he started in July, that's a little bit of a stretch, because he actually started about 6 months before, together with Ali, sitting down in terms of doing a lot of strategic planning for this program, so that when he came on board starting July 1st, we really could hit the ground running. And I think a lot of you might be aware of the program that we started so far. It touches on all aspects of the hospital, and I said the strengths of Mass General, leveraging the NICU and all of our specialties, and these children have quite a bit of need of ancillary care. And so without further ado, I'd like to introduce Brian, and just as an additional measure, just to say that he's a very talented individual. We were really lucky to get him. He's very organized. He's well respected in his field already. He's made it a passion of his to advocate for children with intellectual disabilities. He's on the Massachusetts Down Syndrome Congress Board of Directors. He's also on the advisory committee to the National Down Syndrome Committee. He's published several books. One book, Common Thread, Celebrating Life with Down Syndrome. Another one, Fasten Your Seatbelts, a crash course for Down syndrome for brothers and sisters of kids with Down syndrome. He's a very talented speaker. He's been on radio, published widely, including the Wall Street Journal and other articles. And it's our pleasure this morning to have Brian with us. Thanks so much, David.
Thanks so much, David. It's really a pleasure to be here, but this is just really the first of a two-part speaking series. And coming up, let's see if I can advance this. Coming up in the spring, my friend and colleague and fellow co-director of the Down syndrome program, Dr. Ali Schwartz, whom you all know, is going to be speaking about her area of expertise, and that's successful transitions for young adults with Down syndrome. And I think both Ali and I want to echo all the things that David said and express our gratitude first to Jose Flores, who came up with the idea in 2001 and opened the clinic in 2006, seeing the first adult patient with Down syndrome. And we also want to thank Dr. Kleiman and Dr. Sweetser for believing in our program and allowing Ali and I to work with an incredible cast and crew to build a Down syndrome program that really provides comprehensive care. That is from infancy all the way through the whole lifespan. And in case you're thinking it, and I know there's two of you out there, Ali and I are not married. We are both happily connected with other individuals, but we are We get that sometimes, but we are happily part of a bigger team, a bigger clinical team, and this is our clinical family. So these are the 5 physicians in the Down syndrome program. Allie, of course, does it all as Med Peds trainee, so she sees both adults and pediatric patients. I see patients in the pediatric realm in the Down syndrome program, and Jessica, Talia, and Jose all see individuals in our adult Down syndrome clinic. And when individuals come to our clinic, no matter what age, they're also going to be seen by all of these incredible people who make up our Down syndrome program. Tommy Toller is our program coordinator. Helen Weiner is our social worker. Ben Majeski is our resource specialist. Sandy Maslowski is our office assistant. And Melissa White is our clinical nutritionist. And it's really been wonderful working with all of them. And then our program has 4 distinct clinics based on the age of the person with Down syndrome. So we have an infant and toddler clinic for individuals between the ages of 0 and 5. And like I mentioned, they'll see one of us physicians and all of those people on the previous slide. But in that group, we also tailor it, and we've developed a collaboration with audiology and ophthalmology at Mass Eye and Ear Institute. And then we also have 3 outstanding therapists, Anne from physical therapy, Sharon from occupational therapy, and Michelle from speech and language, who also see all of our patients every 6 months in the infant and toddler clinic on the same day as the visit. And then for those patients and their families who desire it, we could also arrange for same-day dentistry. So it's really a full day for these individuals, and we follow them every 6 months up until the age of 3 and then annually thereafter. When they get a little bit older, they start to join our child clinic. And again, they see one of us physicians and the same cast and crew. We believe strongly that everyone needs to be seen by our nutritionist, our social worker, of course, Ben, and our program coordinator. They too go over to Mass Eye and Ear to get their audiograms and to get their ophthalmologic appointment. But we also feel strongly that so many of these individuals have behavior needs and psychologic needs that we have paired up with Lena and Kay from the Psychology Assessment Center here at MGH. And on the same day of the visit, everyone gets seen by these 2 incredible clinicians who are working with the families to go through behavioral needs, to go through assessing any dual diagnoses, to go through looking at how to implement all of the suggestions into the educational plans. And then if families need it, we also involve same-day dentistry. When they get a little bit older, they start to join our adolescent and young adult clinic. And here they see all the same cast and crew, and they also go over to Mass Eye and Ear, where they get their audiograms and their ophthalmologic appointments done. And then we have our long-standing and our historic now adult Down syndrome clinic, and this is Dr. Jose Flores and Ben Majeski talking about prepping for one of our patients, and they have the same sort of lineup where they also go to audiology and ophthalmology. On the same day of the visit, many of you know we're situated in Yawkey, Yawkey's 6C, so they're able to get their blood work done and also able to get any radiologic imaging done on the same day of the visit. So it is a long day, but we prep the families for it, and families do seem to appreciate having everything done within the confines of one day with everyone coordinating and talking together rather than having to come back for multiple visits. So for today's talk, neither my wife or I have any financial relationships to disclose. As you heard from David, I do volunteer proudly in a non-paid capacity with some nonprofit organizations. And I also have one of my many motivations is a sister who has Down syndrome. The goals of this particular talk is to share with you how can we ensure that all patients who especially come through the doors of MGH receive the best medical care as it relates to Down syndrome. What are the most common medical conditions that I think all of us could help collaborate with? And what are some healthcare resources that are available to all of us as physicians? I'm not going to talk about the newborn period. The newborn period is a talk in and of itself. So we're going to kind of talk after they've been discharged from the hospital, after they've been born. Where do all these guidelines come from? Well, many of you know that the American Academy of Pediatrics publishes consensus guidelines. And back in 2001, we had 2 competing sets of consensus guidelines, one published by all clinicians who ran Down syndrome clinics, the Down Syndrome Medical Interest Group, and the American Academy of Pediatrics. In many ways, these were complementary and overlapping, and in many ways that they offer disparate views. And so many of us who were involved in Down syndrome clinics at the time really had to straddle which of these and how are we going to implement this. This fortunately changed last year in August of 2011 when the American Academy of Pediatrics came out with an updated healthcare supervision guidelines, and the Down Syndrome Medical Interest Group had wrote that competing set have now ceded their authority to the American Academy of Pediatrics. So we now have one set of guidelines, which is really nice for us to operate on. As many of you know who work with populations that have guidelines, every time a new iteration comes out, it gets longer and longer and longer and more to do. And we make sure in our clinic that at bare minimum, people leave our clinic being up to date on the recommendations from the healthcare guidelines. We also feel strongly that parents who we work in collaboration with should have access to these guidelines. So I was involved with a group who worked with the National Down Syndrome Society, one of the national Down syndrome groups, to really write these checklists for parents. So parents could go to this website, download, my kid's 5 and has Down syndrome, my kid's 10 and have Down syndrome, and they could get the guidelines and take them to their local primary care physician to really determine what needs to be done. As many of you know, we are a subspecialty clinic, so we work on purpose in collaboration with all the primary care physicians. We cannot do it without them. We see patients primarily once a year, and all of our notes go back to the primary care physicians who we continue to collaborate with throughout the year. So what I'd like to share with you is some of the common concerns we get in the Down syndrome program. We have everyone complete an intake form before they come in, and we say, what are the top 3 things you want to talk about? And then Allie, myself, Jose, Talia, and Jessica look at those and we try to prep for clinic. So what I thought I'd do is give you in Family Feud fashion kind of the top concerns and just walk you through how we typically work them up and what are some things we look out for, particularly for our friends with Down syndrome. And if there is one concern that always seems to be on the list, and that is my child has some difficult to manage behaviors. Yes, children with Down syndrome are a delight and families brag about them and they're incredible, but behind the scenes when they come in, there are usually 1 or 2 behavioral concerns that they have that they haven't had necessarily space to discuss. And usually our clinic is the opportunity to discuss this. It's so common that we've come up with a Down syndrome behavioral checklist. And the first thing we say is, are those behaviors some manifestation that there might be some medical condition going on? Sometimes our friends with Down syndrome can't articulate to us that something hurts or something's not right. And so behavior might be the only manifestation we get. So we really want to exclude some of the common medical conditions, and I'm going to go through each one of those. And then we're going to talk about expressive language skills, how it could be frustrating when you can't be understood by others. And then we're going to talk about some specific behavioral concerns. So hearing, and I want to extend our gratitude to Ellen O'Neill and all the audiologists at Mass Eye and Ear Institute have been working collaboratively with our program. We couldn't do it without you because all of our folks who come to us in the Down Syndrome Clinic then go through that Lunder tunnel over to the Lunder building, connect to Mass Eye and Ear to get their hearing test done. And the research shows that up to 3 out of every 4 individuals with Down syndrome will experience some form of hearing loss at one point in their life. And if you can't hear well and the world starts to go a little bit silent, that could be very confusing for some of our friends with Down syndrome. And sometimes the only manifestation could be a behavioral issue. So the recommendation is at birth, 6 months, 12 months, and then every year for the rest of your life, we get our hearing test done. And as many of you know, there could be 3 different flavors of hearing loss, conductive hearing loss, particularly in the younger kids, because those ear canals are so much smaller. Sensory neural hearing loss as they get a little bit older, and sometimes mixed hearing loss, a combination of both. But the reason why we screen is because we could do things about it, and it can make a significant difference in the lives of young students with Down syndrome and older individuals as they're integrated into our communities. And we could remove the wax, we could put in ear tubes, we can make sure that they get an FM hearing system and that they have preferential school seating. One of our biggest weapons, as you know, and advocates is Ben Majeski, who works in our clinic, and he could also talk about many topics, and he also talks with our families about what it's like to use an FM amplification system and how it doesn't get in the way of your life. We also want to make sure that the eyesight is okay. When the eyesight goes blurry, sometimes our friends with Down syndrome cannot tell us that that's the case. And so we partner with Melanie Casalas and all of the great ophthalmologists at Mass Eye and Ear to, on the same day, be able to offer those ophthalmologic evaluations. And individuals with Down syndrome can have any number of ophthalmologic conditions, and it's very important to try to detect it early before it becomes an issue. Because so many of these things we could do things about, right? Wearing eyeglasses, we could put in drops, we could correct the cataracts before they become an issue. And lacrimal duct obstruction tends to be very common, especially in the young ones with Down syndrome. The recommendation is if you have no eye issues whatsoever, your vision is perfect, then you should still be seen annually between the ages of 1 to 5, then spacing out every 2 years between that 5 to 13 age group, and then every 3 years between that 13 to 21 age group. And this is why our clinics are also conveniently chunked into those same time ages so that we can match the guidelines and provide consistent care. Thyroid issues. If there's one hormone that kind of goes with the show with Down syndrome, it's thyroid. And here are the symptoms. If someone with Down syndrome is tired, sluggish, has constipation, is unusually cold, hyperactive, sweating, restless, diarrhea, or having any behavioral problems, it could be the thyroid. And since anyone with Down syndrome has one of those symptoms or one of those complaints at any time, this is why the American Academy of Pediatrics recommends that thyroids be checked every year for everyone with Down syndrome, regardless of their symptoms. So this is something that we routinely do, and thyroids can change over time. Some of you who are not familiar with thyroid levels, the first level we draw is a TSH value, which is a signal from the brain that goes to the thyroid gland, and the thyroid gland produces free T4. And it's really these two levels that can give us a picture of how well this communication or this access is working. Individuals with Down syndrome often have hypothyroidism, meaning that this gland is not producing enough, and so the brain signal says, come on already, and the brain signal is overproducing. We see this pattern we call hypo or too little thyroidism. Hyperthyroidism is when this gland is on overactive drive, producing way too much, and then the brain signal says, slow down. And this could be the case with Down syndrome, but not as frequently as hypothyroidism. The one condition that seems to go along with Down syndrome more often than anything else is something called compensated hypothyroidism, or a fancier word, hyperthyrotroponemia. And this is where we measure this value and it's completely normal, but when you look at the signal from the brain, it's high. And why could this be? It could just be a temporary roller coaster that the brain signal is taking. We check in 3 months and that signal comes back down and we do nothing. Or we're starting to see early signs of an autoimmune process where that brain signal is trying to really exhaust that thyroid gland. And Ali and I have worked in conjunction with Takara Stanley and Paul Bopel in order to come up with a way of evaluating people who fall into this category. And if they have too little thyroid, we add levothyroxine. If they have too much, we could treat with medications. And then we have a whole protocol that we've developed so we could all consistently deal with this very difficult and nagging third problem, and that is when one is high and the other is normal. And this is why we really need to check both values, because if only free T4 was checked, it could have looked like a normal picture when really we see a high TSH going on in the background. Even if someone doesn't have behavioral problems, we're still checking for thyroid. Another thing, if someone is having behavioral issues that we check for, is celiac disease. So up to 5% of children with Down syndrome are believed to have celiac disease, and the recommendation is beginning at the age of 1. If there are any symptoms, we would screen for it with blood work. As many of you know, that's the total IgA and the tissue transglutaminase IgA. But the symptoms could be so broad in our friends with Down syndrome: diarrhea, constipation, bloating, behavioral problems, vomiting, and abdominal pain. I remember I was seeing a girl, and she came, and mother said, I don't know, for the past 6 months, her behavior has been terrible, and the teachers are writing notes, and I don't know what's going on, and she hasn't been like that. And you're going through the visit, and at one point you say, oh, what do you do? What does your husband do? Oh, my husband's a baker. He loves to be a baker. And you just know, as soon as one parent's a baker, it's going to be celiac, right? You get the blood work done, and of course, the girl has celiac disease, and the family needs to go on a gluten-free diet, but then they come back, and they don't realize what life could have been, because you've been tolerating these symptoms, these feelings, this bloating for so long, that it could really cause a dramatic change. My own wife was diagnosed with celiac a couple of years ago, and I could say that life can be just as nutritious by eating gluten-free by proxy when you have celiac disease. And our colleague Ben also talks to families about what it's like to live a gluten-free and a healthy diet. And I have to say that it's been great working with Garrett Zella, Kristen Ganguly, and Jess Kaplan for working with us on some of the difficult TTG values that have come back in some of our patients. Constipation. As Ali and I like to say, kids with Down syndrome are constipated until proven otherwise. They really like to pack the stool in there, and it's so important to ask the most simple question: is your child having a sizable regular bowel movement? on a daily basis. And if the parent hesitates or says, well, I don't know, I don't watch them go to the bathroom, or yeah, they're regular, they go every other day, and if there are behavioral issues, and because people with Down syndrome can't tell us what's necessarily always going on, sometimes we choose to get an X-ray, a KUB. For those of you who aren't familiar looking at KUBs, black is air, and you can see here are the bones here of the spine and the hip and the ribs coming down here. This is your colon here. So your colon ideally would just have lots of blackness or air and not be full of stool. But you could see these stool balls pack, 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 pack. This is an abdomen just packed with stool. And this is an 8-year-old whose mother came to me and just said, she's driving us up a wall. That was her only symptoms, behavioral symptoms. So we looked at this, and this is like my makeover slide, the before, and then my makeover afterwards. Isn't she beautiful? Look at her. So you could see that all this stool is gone, and you know, you go through all this training in genetics, and you memorize all these things for your board exams, and sometimes the most simplest thing of asking about stool and cleaning it out can make the biggest difference. This mother came back and said, oh, she's a different girl. The teachers were excited. It was simply a matter of cleaning out that stool. Now, constipation could be a result of a couple of also conditions that go along with Down syndrome. So hypothyroidism goes along with Down syndrome, can lead to constipation. Celiac could go along with it. Some friends with Down syndrome also have a tethered cord, so we look for reflexes, and that could result in constipation. But it could just be good old-fashioned Down syndrome, and the hypomotility of the colon leads to things like this. Many of you know there's lots of ways to get that stool out, and we come up with all sorts of ways of doing this. You could really bulk it up, soften it, lubricate it, help push it out, or water down the stool. And depending on the patient, we do try lots of those, but we tend to start with Miralax. And sometimes, since hypomotility is a common reason, we'll need to add Senna for a short-term or sometime long-term basis. When they're really packed, they get to have a fun weekend where we've come up with, in conjunction with our friends from GI, this constipation clean out, where over the weekend they really try to clean out, and we repeat the X-ray to see if they're cleaned out. Parents will say, oh, so much came out, and we get the repeat X-ray, and they're just as packed, which amazes us in how difficult the constipation could be. Sometimes this doesn't work, then they need to be admitted for a go lightly clean out, and every once in a while, probably once every 2 years here in the Boston area, someone needs to be admitted for a surgical clean out because it could be so tough. So it's something we really pay notice to in our clinic. You know, what's so nice about our intake forms is we get pictures, we get binders, we get invitations to bar mitzvahs, and all these sorts of wonderful things that parents send us. And every once in a while, they send us a picture that's a gem. And this is a mother who says, my little boy is driving me crazy, right? And we know instantly what this child has by looking at this picture, don't we? This boy actually has a very serious medical condition that goes along with Down syndrome, and that is there is no air getting in there. Look at those whopping tonsils. This is a child who has obstructive sleep apnea. And obstructive sleep apnea is quite a serious comorbid condition that goes along with Down syndrome. Up to 3 out of every 4 individuals will experience it at one point in their lifetime. So common, with the symptoms sometimes scant, that the American Academy of Pediatrics changed last year and said everyone with Down syndrome, regardless of what symptoms you have or you have not, at the age of 4 needs a sleep study. And if you're older than the age of 4, you need to make it up by getting a sleep study. Of course, if the child answers yes to any of these questions, which we screen for on our intake form, do they snore, do they gasp, do they choke, do they fall asleep on short drives, do they nap and age in appropriate ways? Do they not seem refreshed during the day? If they answer yes, then definitely we're going to be getting a sleep study again, even if they already had one. But even if they answer no to this, we're going to order a polysomnogram or a sleep study. And that's because research has shown that there was one study that asked parents who had kids with Down syndrome, do you think your kid has sleep apnea? Yes, no. And then they went for sleep studies. And there was no correlation between a good mama instinct and whether or not they had sleep apnea, which shows how difficult it can be to pick up sleep apnea, especially in kids with Down syndrome. Looks like they're breathing, their chest is moving, they're sleeping a long time. Oh, they have behavioral issues. Oh, they're falling asleep at school. But that's just the way those kids are, is what they hear. Well, no, in fact, they actually might have obstructive sleep apnea. And we've been working closely with Craig Canapari and Mike Cohen in order to get the sleep studies done. And then if it looks like there is sleep apnea and the tonsils and adenoids are enlarged, then the next treatment is go for an adenotonsillectomy. If they go for an adenotonsillectomy, it tends to be curative of that sleep apnea about 70 to 80% of the time. And that's why we get a post-op sleep study just to show what was there before is gone afterwards. And if not, then we have to resort to other measures. And we work with Craig and Mike closely in order to provide specialized and individual care. So again, this is someone who came to our clinic who wanted to talk about behavioral concerns, right? And you have 40 minutes or so to kind of get this all in. And we've just talked about and worked our way through the most common medical conditions. If we kind of rule those out or we minimize those, the next thing we're talking about is expressive language skills. Because if I were in Japan right now and I wanted to order food and I didn't know how to speak the language, which I don't, it's going to be really frustrating. And sometimes I try to remember that when our friends with Down syndrome are navigating in the world where it's clear what they're saying, but they're not articulating or being appreciated well. And that could become very frustrating, which leads often to behavioral issues. So in clinic, we talk a lot about language issues. And when they're younger, sign gestures or baby signing time is a great way for people and younger ones with Down syndrome to use their arms when they're waiting for their words to come in. Augmentative alternative communication has really opened up the worlds for our friends with Down syndrome, and particularly those in school who need to communicate with them. Many of our patients are starting to get iPads, and with the iPads they could download programs like Proloquo to Go, where it's on their iPhones, it's on their iPads. When they get stuck and no one can understand what they're saying, they pull it out, they press a couple things, and then the device actually says in a mechanical voice, "Hey, dude, I want to play soccer today." "Well, we can't play soccer today. We're going to play football today." "I want to play soccer." "Well, dude, maybe tomorrow we can play soccer, but right now we're going to play football." "Okay, tomorrow we're going to play soccer." And what they just had was a normal kind of competitive back and forth guy talk on the playground that if they didn't have that opportunity, would have resulted in a temper tantrum or a smack or a hit or something, right? And they were able to engage in that because someone had a device to communicate while they were waiting for their words to work in. And we work very closely, like I mentioned, with Michelle from Speech and Language Pathology to really provide great advice for speech and language therapy, but also to decide when it's appropriate to make that referral to get an alternative or augmentative communication device. So much of what we do in clinic is to provide information and brochures. And there's so many great resources out there, and we really consider ourselves kind of a conduit in making sure parents read this, look at that, and oftentimes we'll give parents homework when they go home to say, this is the book you need to read, or this is the DVD you need to watch. And Woodbine House has a lot of these books. This is a DVD by Libby Cumin that talks about how to enhance and improve the speech skills in our friends with Down syndrome. These are two staples, just to give you an example, a book for the younger kids and a book for the older kids, a book specifically for parents and speech and language pathologists, again, how to maximize the speech skills in our friends with Down syndrome. So once we have ruled out some of the medical issues, we've maximized their language. If there are still behaviors that are going on, we need to really start to think about other things. And Allie and I work closely with Janet Sherman and Margaret Pulsifer from the MGH Psychology Assessment Center, who we have to thank believed in us right from the beginning and said it's really important to have a psychologist embedded in your clinic, and it's really paying off. And we work with Kay and Lena, as I showed you their picture, and they're screening for some of these conditions. So ADHD, when individuals with Down syndrome have difficulty concentrating or paying attention, in two or more settings, can occur at an increased frequency in our friends with Down syndrome. Obsessive compulsive disorder, all of individuals with Down syndrome have some sort of obsessions, but when does it get in the way, right? So my sister with Down syndrome used to like to line things up and used to like to make things, everything was orderly at home, and really frustrated the rest of us kids because she always had the neatest room, and mom always said, why can't you always be neat like your sister, right? Well, then it got to a point at one point in her life when she had a job she really loved. She was always worried about, is my purse zipped up? And she would leave her job to go to the corner to make sure her purse was zipped up. Come back. Is my purse zipped up? She would constantly be checking to see if her purse was zipped up. Well, you don't send her to work with a purse. Then she was worried about someone else's purses being zipped up. She had obsessive compulsive disorder. It had gotten to the point where it was starting to inhibit the life that she wanted to lead. And these individuals who have this co-condition really do benefit from medications. And we've worked closely with Chris McDougall and Elizabeth Pinsky and others in order to prescribe the right medication for the right dosage to get our folks back to the lives they want to live. Depression and anxiety, a word here. Our friends with Down syndrome tend to feel hard, longer, and long-lasting. So it's not uncommon to see a teenager in our clinic, and mom would say, she's just not the same she's been since my mother or her grandmother passed away. It's really sad when grandma passed away. When did grandma pass away? 5 years ago. As though it was yesterday. She's still perseverating on that. They get stuck sometimes. They think about grandma. She just hasn't been the same since her brother went to college. When did brother go to college? Oh, he's now a senior, so it was many, many years ago. She kind of, she's still thinking though it was yesterday, right? So anxiety and depression sometimes can get in the way, but what we don't offer as excuses, that's just the way they are, or they have Down syndrome. And so because we're able to work closely with our psychologists and our psychiatrists, many of our individuals now are benefiting from the same medicines that are benefiting the typical population. There are some books that rise to the level of everyone needs to have, and this is one that we recommend if a family has a young adult or adult really to have. And Allie and I love the title, Mental Wellness. It's really talking about the health of our mental state and making sure that families, when they read this book, there's usually a chapter in there they go, that's my kid. And they realize, one, they're not alone, what are some behavioral techniques, and when that comes short, what are some medicines that really work for some of these other conditions. Autism spectrum disorder. So up to 18% of individuals with Down syndrome are believed to fall on the spectrum of autism spectrum disorder, and 6% meaning the classical definition of autism in the latest version of DSM. Of course, they need a full neuropsychological evaluation. And what are the three things? Same three things in the typical population, but you can see how this might be difficult to tease apart when it's embedded and overlaid with Down syndrome. So significant communication difficulties, to the point where people with Down syndrome might be nonverbal or they don't want to communicate. It was very difficult for them to communicate, even at later ages when language should have set in. Difficulties with social skills. People with Down syndrome tend to be social, not all. They tend to be interactive and gregarious, but individuals with the dual diagnosis prefer to be alone, prefer to be in the corner, don't prefer to make eye contact. They're really kind of distinct from the typical person with Down syndrome. And then repetitive behaviors, many of the same that occur in individuals with autism without another diagnosis. So hand flapping, hand twirling, biting fingernails, doing things in a repetitive manner. So certainly Allie and I screen for this in the pediatric population, but it's so great to have Lena and Kay embedded because they too can give us on the same day their assessment on whether or not it's looking like this person is meeting a dual diagnosis, because then they'll be referred to Kay and another day to get the full neuropsychological evaluation. And this is important because people with Down syndrome with the dual diagnosis benefit from ABA therapy. And oftentimes, as many of you know, unless they have that other diagnosis, they're not going to get the amount of hours that they need. So diagnosis could really lead to more therapy and treatment. But for many of our patients, including one we saw last week, the mother came in and said, I just never felt like we belonged in the Down syndrome community. My kid was a little bit different. And when you give that other diagnosis, there's a sense of relief all over again. There is a something else. It's not because of any lack of parenting skills that they didn't make their kid with Down syndrome the superstar. There really was something else going on. But many of you know that in the genetics revolution, there's lots that we could do to look for another cause for autism. And this is one of our practice guidelines. And this is a table there that there are some conditions in genetics we feel, it's caused, it goes along with autism. And there are some over here that we feel we're not quite sure whether it's a one-to-one cause relationship with autism. You can see Down syndrome is listed here, and I think the primary reason is since Down syndrome is so common, and since autism is so common, two common things could co-occur in the same person at the same time. So the recommendation, at least according to this guideline, is that people with Down syndrome can merit from a genetic workup or a metabolic workup for autism spectrum disorder. Now, it's really dependent upon whether insurance companies are going to pay for this, and we sit down with the families and we say, this is an option, here's what we test for, here's the results you would get, and do you want to go through that? And these are several things that we can test for according to the guidelines, but we oftentimes really personalize the list based on what we think is most appropriate given the clinical situation. But again, we really want to make sure that that couple has insurance coverage because we don't want them to get a bill with a copay for multiple thousands of dollars, which these tests could quickly add up to. Then when you go through all of that and there's still bad behavior, we unfortunately have a diagnosis we could bill for, disruptive behavior not otherwise specified. And a lot of individuals with Down syndrome do fall into this category, but it's important to get a functional behavioral assessment, that is having the school doing that observation to give us more feedback. There is a lecture series I was a part of when I was at Children's on behavior and Down syndrome. We sometimes share, and we work with our great cast and crew here in order to make sure that they get the updates that they need. This is a great book, a funny book, a straight tell it, shoot it from the hip book that many families do like, and we mentioned it. All right, so that was our number one concern in clinic, and typically we try to get through 3 concerns. So you can see why clinic is a jam-packed day, and this is why we collect all the information ahead of time so we can really deliver assessment and advice right from the beginning of when we step into the room. The next thing we often hear is, I'm concerned about my child's weight. And I'm so glad that many parents are, and many of you know, there are growth curves that are specific to Down syndrome, and some of you have been so diligent to make sure that we're plotting individuals with Down syndrome on those growth curves. But with the new guidelines, they say throw them out. And the reason why we're now throwing out those growth charts is those were built on data from about 1960, and it's no longer believed that the people with Down syndrome who lived in 1960 benefited from the full medical care and the nutritional care that are available to them today. So there are a couple of groups that are building new guidelines, our new growth charts specific for Down syndrome. But until that day happens, the recommendation is to use the typical age-specific growth curves. But we're really looking at height versus weight and BMI, because our friends with Down syndrome are going to be shorter, right? But these 2 ratios really take that into account. If they're greater than 85%, like the typical population, they're considered clinically overweight. Greater than 95%, they're considered clinically obese. And this is why we have Melissa White embedded in our clinic, a nutritionist. We're trying to make changes at a very young age and continue to follow people over time. So when that metabolism slows and those pounds start to be put on, we could start to educate them ahead of time and stave those off. Individuals with Down syndrome are more prone to diabetes than the typical population, so when they become overweight or obese, we start to screen for this, and sometimes we'll add cholesterol and liver function tests, which some studies have shown start to show abnormalities when they become overweight or obese. There's also a booklet just for our population, the Down Syndrome Nutrition Handbook, and we mentioned this to families, and it's certainly one of the things that Melissa works from during our clinic. Many of you get this question. There's someone with Down syndrome who wants to participate in sports, or they're going for surgery, or we're seeing them on the ward, and I just remember there's something with the neck we're supposed to worry about. So atlantal axial instability and occipital axial instability goes along with the show. But this is one of the most remarkably frustrating things, I think, to deal with, both from the medical community and from the parent community, because it just doesn't quite predict well. So about 15% of people with Down syndrome will have one of these conditions, and that's where the ligaments between the occiput or the first and second vertebra are not tight enough, so there's a wiggle there. And if the wiggle is too great and the movement in the wrong place at the wrong time, you could cause spinal injury or spinal damage. And you do hear once or twice a year somewhere in the country someone with Down syndrome is paralyzed and they're going into the hospital because they had this and it was unrecognized or they were involved in dangerous sports. But the chances of that happening are very small. But since the consequences are so high, do we screen with C-spines or not? Well, this is what the literature shows. The C-spines do not predict well which children are at risk. If you get a normal C-spine, it doesn't mean your child won't develop AAI or OAI later. However, if your child wants to participate in Special Olympics or any of the athletic competitions, they're requiring it for entry. So then they come to us and say, well, we need that C-spine anyway. And we want our individuals with Down syndrome to be athletic participants and get good exercise. And so we end up doing the C-spines almost all the time anyway. But the official recommendations, they're not recommended if someone is asymptomatic and doesn't need them for any athletic participation. Here are the symptoms, though. And this is such that we try to educate everyone in our clinic about these, and we even have a handout that we now give parents saying, on your mom and dad thought list, if at any point in their lives these things start to occur, this is when you need to seek medical help. So change in gait, change in use of arms and hands, bowel or bladder function, neck pain, anything with the neck, new onset weakness or hyperreflexia, anything where that spinal cord could be damaged. And if they have those symptoms, then we get not one, not two, but three views of the C-spine. I have to thank Katie Nimkin, who we work closely with to develop a protocol, and Jeff Creer in Orthopedics, who is helping us manage some of these patients. And you could see these hatch marks. That is the distance that is being measured. And we're measuring, or really Katie and the radiologists are measuring millimeters. And anything greater than 4.5 millimeters, that's not arranged correctly, means that someone has AAI or OAI, and it means they're at risk. If you're at risk, what do we tell them? Well, we have a letter that goes to the parent that could be used in school. We really want to avoid those athletic activities where the neck is moving a lot. So contact sports, gymnastics, horseback riding, diving, trampoline usage. And we want to make sure they have extra careful precautions during anesthesia. So that is OAI and AAI, still unfulfilling, but we're doing a lot of C-spines just because they're required, and then we need to deal with what the results say. If they do have OAI and AAI, we're tending to screen about once a year because some of them actually do tighten up over time. Some of them who are normal develop it later, so they could cross in both directions. There are certain comments we get that we have to pay extra special attention to when we get them from a parent who has a child with Down syndrome, and that's limping and leg pain. One, it can mean hip dysplasia or dislocation. So up to 4% of individuals with Down syndrome, that hip is just not tight in place. And every once in a while you hear a mother or a father who says, my child's always complaining of their knee. Their right knee really hurts. And they go and they get a knee x-ray, and the knee x-ray is perfect. But as many of you know, when a joint hurts in one of our pediatric populations, we really do want to x-ray the joint above and the joint below. So when that knee hurts, it might be referred pain from the right hip. And it's not uncommon that that is the presenting symptoms. And our friends with Down syndrome really do need to have surgery and immobilization because when they have that hip dysplasia and dislocation, oftentimes it's not going to go back in place. And we really do want to prevent some of the long-term consequences, including arthritis later on. Of course, limping and leg pain could also be signs of leukemia. Many of you know that leukemia occurs, particularly AMKL, at an increased incidence in individuals with Down syndrome. But even at an increased incidence, it's still believed less than 1 out of 100 children with Down syndrome will go to develop leukemia. There's two types in childhood that seem to occur, ALL and AML. ALL tends to peak in children with Down syndrome between 3 to 6. They're less likely to have the large spleen and chest mass and central nervous system, but there are always exceptions. And with AML, it tends to peak between 1 to 5 years, and there could be a history of TMD, which we're going to talk about. This is a blast or a baby white blood cell, which is the cause for the leukemia. And they respond to chemotherapy, which our great oncologists here know how to tailor specifically to meet the needs of people with Down syndrome. Well, let's talk about those blood cell types because you have children with Down syndrome, either outpatient or inpatient. They get a CBC, and there's always something that's high, low, left, or right, and you're always wondering, is this normal or not? Because the computer flags for the typical population. So those of you who are not directly involved in medicine, we have 3 different types of cells. Red blood cells are going to carry oxygen. Platelets are going to prevent bleeding, and white blood cells help us prevent infection. Here are the words that we use when this particular column is too high. Here are the words we use when this particular column is too low. And individuals and babies and children and adults with Down syndrome could have any number of these. And unless they're at the extreme, oftentimes we're just providing reassurance. So much so, it's no longer the recommendation to do CBCs on everyone with Down syndrome after birth because it just causes a lot of values up or down, which lead to unnecessary tests, parent worry, that we end up doing nothing about. If there is something in the extreme, usually there are symptoms that go along with it, which we would get the CBC with differential anyway. I want to talk briefly about TMD, or transient myeloproliferative disorder. This is a condition that occurs in babies with Down syndrome, and this is where they have lots of blasts, or those baby white blood cells. So it occurs, according to some research, 10 to 20% of babies, and this is why we do a CBC with differential for every baby with Down syndrome who is born. If it's present at birth or within the first few weeks of life, it typically, although not always, resolves in the first 3 months of life. And we work closely with David Sweetser and his team in hematology to come up with a general rule that, of course, needs to be modified on an individual basis. But if they fall into this TMD category, we're going to be really closely monitoring those CBCs with a hematologist every 3 months until 3 years old and every 6 months until 6 years old, again with some individual variation, just to monitor and make sure that that doesn't convert into AMKL requiring treatment. One thing we are screening for in individuals with Down syndrome is iron deficiency anemia for a couple of reasons. The diet is not perfect in our friends. Many have low dietary intake of iron. And since MCV, which we've typically used, in the general population, if you have iron deficiency, you're going to look at the hematocrit or hemoglobin, and you're going to look at the MCV, and you're going to use that to make a determination. But the challenge is with individuals with Down syndrome, their MCV is normally elevated in comparison to the typical population. So if you have a value that looks normal, it could be artificially high because that's their baseline. So the recommendation and the research has shown looking at hemoglobins, and if the hemoglobin is less than 11, then the follow-up test that's recommended is to get a CRP and ferritin or a reticulocyte hemoglobin. And the reason why the CRP and ferritin is got, because both of these, as you know, could be acute phase reactants. So if the CRP is elevated, then there's something else going on. Maybe there's an infection or what have you. But if the CRP is normal and the ferritin is off, then we could trust the ferritin as maybe there being iron deficiency anemia. If there is, we work with our nutritionist to try to increase the iron intake, or sometimes we need to prescribe iron supplementation for people with Down syndrome. My child is drinking a lot and going to the bathroom excessively. So diabetes, of course, comes to our mind and should come to the mind when we've seen someone with Down syndrome, because about 2% do go on to develop it at some point in their lives. It's the same types, the same breakdown, and the same medications really are helpful. And we're screening for our hemoglobin A1Cs in clinic if we get any indication that there is excessive thirst or excessive going to the bathroom. Runny nose and congestion. Sometimes, like constipation, it's the simplest things that can make the biggest difference. And everything in here is a little bit smaller in our friends with Down syndrome. So the same gook in us is going to clog up the whole system. And then they feel under the weather. Then they're misbehaving. Then they're not doing well in school. So we really do try to be aggressive in the treatment of seasonal allergies. And we usually pick one systemic medication and one local medication. And parents really come back and say, that made a huge difference, just that little thing, in terms of my child being able to breathe better. Sometimes we'll get RAS testing if it does seem to be a specific allergen that we want to look for. And we recommend starting 2 weeks in advance of the season, of course, all during the season, and 2 weeks after the season, using it as a systemic medication rather than as an acute medication. What about my child's heart? So in the newborn period, all sorts of heart configurations can happen. But this is not a talk about the newborn period. So why am I bringing up my child's heart? Well, it's been fascinating to follow the literature because we're continuing to learn more and more about cardiac anatomy. And we've been finding that as individuals with normal or constructed hearts that have been fixed at childhood approach the adolescent stage, there are some new heart issues that tend to develop, and they primarily deal with the heart valves. And so we're really starting to be careful about screening for some of these symptoms. Does your child really seem to be more fatigued? It's always a difficult one to tease out because maybe they just don't like gym class and they look like they're fatigued, but it's a behavioral thing and it has nothing to do with their athletic abilities. But are they short of breath? Do they really have exertional dyspnea? Is there a new murmur? And if we answer yes to any of those, then we're working with our great folks in cardiology to get an echocardiogram to see whether or not one of those heart valve issues has started to develop. All right. A little pause in action. Let's see here. Well, if it doesn't go on, you always print out your slides, right? So you know the next issue. So I'll go on. So the next one is how do we keep our sons or daughters' healthcare records up to date? These families who come to see us are families, as you can see, who are juggling lots of medical issues. Down syndrome is really in the background. There we go. Down syndrome is in the background, but they really have lots of medications. They have lots of different providers that they are seeing. And so we're a real fan of trying to give them tools or resources that are free that can benefit lots of other individuals. Many of you might have seen Footprints for the Future. What this looks like is you download it, and it's a Word document. It's one of those where you could type in and you could save it. and you can enter all the other healthcare conditions, the insurance, when they had the surgery, when they did this. And I have to say it's helpful for a number of reasons. One, when I moved away to college, I said to my mother and father, of course, in regards to my sister with Down syndrome, I think we really need to develop one of these life plans. I heard about it, I talk about it, etc. My mother's response, classic Sharon Skotko, said, "Oh, don't worry, I don't plan on dying anytime soon." And I said, "I'm so glad, Mom, it's not in your game plan." But it's really important as a sibling to have some of these documents, so if the unforeseen or unfortunate does happen, we really would know what are the insurance, where are Kristen's doctors, etc. And this is a conversation we have with families at a very early age when they come to the Down syndrome clinic, and particularly for siblings who want to make sure that they know the game plan. So I'm based in Boston with my wife. Kristen is in Ohio. My other sister's in Indianapolis. If something were to happen, we're not in Ohio, but we all have this document, which is updated once a year, so we know who to call, what to do, and we have this game plan. It's a very awkward conversation. No one likes to have it. I'm including my own sister with Down syndrome, but it's better to have a plan than not to have a plan. Where can families get this? They go to the eMark, based right here in Massachusetts. They click on this. They download it for free. And this was made by Joanne Simons, who is the executive director, former executive director of the eMark, who also was the mother of someone with Down syndrome. And doesn't the greatest inventions come from moms and dads who needed to make them out of necessity? If you want more about Down syndrome, I wanted to mention that through Harvard Medical School, I created a continuing medical education course where you could get credits for taking a quiz about how to treat individuals with Down syndrome. If you do see someone with Down syndrome on inpatient or outpatient and you think that they would benefit from our program, thanks to Tommy Toller, our program coordinator, we have a web page where all the information is there. If you send them there, they can click on request an appointment, and the intake forms are there where they can print out the intake form and send it in. Tommy maintains a Facebook page. He also maintains a Twitter account, and we have an email set up that it goes directly to Tommy, so Tommy can know how to triage any particular requests. I just want to say, concluding the way I began, I couldn't do it without an exceptional team. Everyone here makes coming to work so much enjoyable, and it's been great learning with all of you and many more who I've yet to meet in my introduction here to MGH. Thank you so much. And I saved some time at the end for questions, or I'd love to hear your experiences with people with Down syndrome here at MGH.
Yeah, I think I can speak loudly. I have two prevention questions for you. What causes do you think the valve problems later? Are there some infection prevention issues that are things that could get missed? And then the second question has to do with whether you recommend preventative bowel treatments from children on up. I know in some places I've seen it done, in other places not.
Yeah. Because
by the time the constipation gets to a point, it's the bowel loses even more tone. And so what are your recommendations?
Great. So I think the honest answer to the valve question is I don't think people know, and I haven't seen any research pointing to a specific reason for the valve or whether early infections might lead to it. I suspect there are probably some genes on that 21st chromosome that are programmed later on in life to maybe lead to valve issues, but it's just unknown at this point. There are some people around the country who are doing work on individuals with partial trisomy, so they have 2 and a little bit of that third copy, and by looking what those individuals don't have, they're trying to determine which genes might be determinants for different problems, and they're focusing on the heart right now, so there might be more out. In terms of your other questions about preventative bowel, there are people with Down syndrome who just don't seem to have constipation issues, and my sister at age 30 has never had constipation issues. So, these individuals develop a long list of medications or specialty providers, and if they don't need it, they don't need it. So I really try, if we're aggressive and we're asking questions and we're seeing them routinely, we should be able to pick up constipation and treat when we need it. But it is an open question in those areas that might not have specialty care, whether or not you assume they need the treatment until proven otherwise. And there are families who start to give Miralax, very innocent medication, at a young age. Yes, Frank?
Brian, this is a wonderful talk, and we are really glad to have you here. Have the genetics of Down syndrome provided any insights into why we see the cognitive, emotional, behavioral, mental health issues?
Great question. So the question about, is there something on that 21st chromosome that might be linked to the cognition? So we have finally reached an age where there are clinical trials for people with Down syndrome, and that's because there are drugs that are now targeting mechanisms that, when overexpressed on the 21st chromosome, seem to be linked with cognition. So to give one example among many, GABA is, as many of you know, an inhibitory neurotransmitter, and it's encoded by the 21st chromosome. So if you have an extra copy, you're over-inhibiting. And if you're over-inhibiting, it seems to lead to a depression in long-term memory formation in your hippocampus. And in rat models that have Down syndrome, so it's triplicated on the 16th chromosome, when they're given an anti-GABA medication, those mice or rats in those mazes start to improve their memory. And now Roche is out there with a clinical phase 1 trial for the first time in Down syndrome, testing these medications to see whether or not they might increase the cognitive capacities or the memory in people with Down syndrome. And we're trying to see, as part of our clinic, whether we might be able to bring some of those research opportunities to people with Down syndrome here. Well, thank you so much, and look forward to working with all of you.